So Dr. Kenneth Kuzi is the professor of medicine, and the chief of division of endocrinology, diabetes and metabolism at the University of Florida at Gainesville. His current clinical and research work are focused on the underlying mechanisms and new treatments for NAFLD, NASH in patients with obesity and type 2 diabetes. His session today is a recorded one, and I would request the team to please put it on.
I would like to thank the committee for having me. For me, it's an honor. It's the second time I've been able to join this wonderful meeting, and I really enjoy sharing these sessions with my friends in India and all over the world. In the next 30 minutes, I will share with you what is the latest in non-alcoholic fatty liver disease, what are the diagnostic algorithms. There's a lot of new data this year, and also what are the management strategies that the field is putting forward for this pretty complex problem. These are my disclosures, largely for research done at the University of Florida and for new medications that are making its way to the clinic. For those who don't know where Gainesville is not too far from Orlando, where Disney and Mickey Mouse are. So whenever you come, please, you would be welcome home to share dinner and share our research work. And I promise to not do a liver biopsy on your first visit to Florida. This is our campus, which has 1,000 hospital beds, and also on the upper right, the VA Medical Center with 400 beds. And lots of patients with this problem. And here I just want to summarize what are the key concepts that are important for our conversation today. Number one, it's important to know that there are many causes of fatty liver disease. Many of you may be aware of alcohol and some viral hepatitis medications, but once we rule out all of those factors, we are left with a liver in which our mission is to know if this liver with excess fat is undergoing inflammation and hepatocyte injury, and more importantly, liver fibrosis. Because our aim of diagnosing fatty liver disease is not because of the fat, but because we use it as a surrogate marker to identify those at risk of cirrhosis. Also, we have now linked the long-term observation that people with type 2 diabetes had a threefold increase in the risk of hepatocellular carcinoma, and that link is NASH. So this is what we're looking for, as you see in this electron microscopy picture, fibrosis. We are not particularly interested in fatty liver disease, although we know that that is probably an indicator of unhealthy metabolism and insulin resistance. More importantly, for your day-to-day practice, I want you to link not only what we have learned about cardiovascular disease prevention and nephropathy prevention with preventing cirrhosis in your patients with obesity and type 2 diabetes. Because we have medications that are extremely valuable to treat these different targets and improve the quality of life of our patients. Now, how common is fatty liver? In India, this is a significant problem. In studies basically done with ultrasound, it's at least 60%. But I anticipate that given the prevalence of diabetes in India, unfortunately, it might be higher if we use other imaging techniques. In the United States, I'm going to share some work suggesting that it affects at least 2 out of 3 people with type 2 diabetes. Now, a number of studies, particularly outside of the United States, have looked at this. And in this slide, which is also pretty current and similar to recent studies, if you only looked at liver enzymes, you would say that this is not a major problem. But if you use, as we're going to discuss later, controlled attenuation parameter, which is seen through elastography, and the commercial name is FibroScan, but there's also others called shear wave elastography, you will find that 70% of people with diabetes have this problem. liver ultrasound has lower sensitivity. And again, in research, we also do MR elastography, which is useful, but not for the clinic. At this point, the second problem is that there are many more patients with obesity than type 2 diabetes. The United States, maybe 15% of the adult population has type 2 diabetes, but 40% have obesity. So this is a big problem too. So keep both numbers in mind. And the great dilemma is that liver enzymes alone many times are not elevated about this clinical parameter of 40. Finally, it's important to understand that, as I said to you before, having just fatty liver is a marker not only of insulin resistance, but to its linked association with cardiovascular disease. So in the same way we use proteinuria or albuminuria as a marker of endothelial dysfunction, damage, and risk of cardiovascular disease, in the same way we could use non-alcoholic fatty liver disease. And then when we add the liver damage, particularly when you have advanced stages of fibrosis, this adds the liver component to the morbidity and mortality of these patients. The important thing is that it's common. We can prevent this as it slowly develops over time, although in some patients with diabetes, it happens in a relatively short time span, this rapid progression of the disease. But in general, identifying it on time allows us to prevent significant progression. So this is why this is important. There has been also some confusion with the term. I mean, some people began talking of metabolically associated fatty liver disease. And again, this has created a little bit of confusion. The intentions are good. Non-alcoholic fatty liver disease is a pretty bad term. Everybody's in agreement that you shouldn't, that it's not very useful to call something by not being related just to alcohol. But, and also it would encompass more of a pathophysiological angle and be more inclusive of people having both alcohol and metabolically associated fatty liver disease. However, I just want to let you know that some people think it's premature because the pathophysiology is still not only related to metabolic dysfunction or insulin resistance. There are other factors that we don't understand. There are ongoing trials with the term non-alcoholic fatty liver disease. There could be regulatory problems. And more than anything, my personal view, it reminds me of when we were debating 20 years ago, the insulin resistance syndrome, which I think is the more appropriate term for what is now called metabolic syndrome. That doesn't mean a whole lot. And I'm not sure that all that fighting and debate on finding a good term had led to better care. And at this time that we're beginning to increase awareness and beginning to bring primary care doctors and as me endocrinologists into this field, I'd rather not spend energies on terminology. But just know that this is an ongoing debate, but I would stick to non-alcoholic fatty liver disease. There are meetings we are having this year to reach consensus. Perhaps the unifying finding of NAFLD is the fact that insulin resistance and what I like to call lipotoxicity. This is the adipose tissue, the subcutaneous and visceral adipose tissue are very, very sick. This is not an amount of volume. When you have central adiposity, you have a constant release of fatty acids that are bombarding the liver, and the liver has to deal with this excess amount of energy and nutrients, and this leads to serious insulin resistance and problems. But this ectopic fat affects the muscle where there's insulin resistance. It affects the heart, affecting myocardial function and its ability to tolerate an injury, like in a case of an acute myocardial infarction. We have done studies showing that this ectopic fat impairs insulin secretion if you have a genetic predisposition to diabetes, and clearly it promotes atherosclerosis. So This is an ectopic fat attack that causes toxicity, lipotoxicity across tissues. Now, I get asked a lot, well, what is the contribution of obesity to that of diabetes? And again, this is a difficult question, but we try to get a little bit of at least an epidemiological view of this. And Dr. Barb and her team at the University of Florida took the database with the rest of our research team in this manuscript published in Obesity very recently, and tried to separate the prevalence of steatosis depending on whether you did not have diabetes in blue and by BMI, and those with diabetes in orange. You see that if you are just overweight with a BMI below 30, half the people with diabetes already have steatosis, and this increases by 50% as your BMI goes up to 35, and primarily or basically everybody with a BMI of 40 or above will have steatosis. However, when you don't have diabetes, obesity alone is being overweight alone is not so commonly associated with steatosis. But as you get into the obesity range, it basically, again, is 2.5-fold higher. It doubles almost again as your BMI goes to 35. And practically everybody without diabetes, but with a BMI of 40 reaches this very high level. More importantly, remember what I said at the beginning. Steatosis is important, but really if we want to prevent cirrhosis, we need to look at fibrosis and just focus on the advanced fibrosis. These individuals have pre-cirrhosis. And these were from the enhanced database of 2016. You see that even in overweight, there's a lot of fibrosis, 1 in 10 patients with diabetes, and similar amounts in the obese. But if you look at overweight and obese, 1/4 of individuals with diabetes and slightly less with obesity alone have moderate fibrosis. So they're on a path to cirrhosis. So this calls for a lot of attention from us as clinicians. I'm going to move on, but I just want to explain that this part of the equation of steatosis is probably what primes the system, puts the system under stress. But I have to say that there are other factors, another biology which we don't understand too well, why 2 individuals with the same BMI, same degree of steatosis, one just remains there without active steatohepatitis, while about another similar individual has hepatitis. And a third individual will develop all the way down to cirrhosis, while others will not. So we don't understand that. We are doing a lot of work looking at mitochondrial dysfunction. And I have to say that we do think that mitochondrial dysfunction plays a significant role. And we presented some of that work at the ADA this year, last year, and hopefully more this year. So stay tuned. Now, let's get down to management. This slide is something that I think it's important for you. This is a management guideline promoted by the American Gastroenterology Association, where with the lead of Dr. Canwell from gastroenterology, Dr. Shobrook from primary care, and I, as representing endocrinologists, put together a group of very talented people. And we came out with something to try to begin breaking the silos and working together in the management. And this is being published simultaneously in gastroenterology, in the Obesity Society Journal Obesity, and the American Diabetes Association Journal Diabetes Care, and in Metabolism. And this was just available recently. And what this slide is once you have the phenotype of risk, obesity, diabetes, insulin resistance syndrome, and you rule out alcohol intake, think about other causes of liver disease. And now you're left with NAFLD. And what you want to know is, what is the risk of this person of having NASH with fibrosis? So the real challenge is that we can image fat, we can image fibrosis, but it's very hard. We don't have a good method to imaging inflammation. There are some under development like CT1 wave, but it's making its way through to the clinic, and promising. Now, if you look at the non-invasive testing with FIB4, and I'll tell you more about that, if you are below a given number, you can say you're low risk. And again, that's rules out about half of the people with diabetes. 10% are going to have numbers that are high enough to say, wow, we have a real problem. And again, 30 or 40% are going to be in the middle. For these individuals who we're not completely sure, we will do an imaging test called transient elastography, and then divide them between low and high risk. And those at the very high risk are the ones that we want to refer, because we can't refer 50% of our people with diabetes. What is this thing of the FIB4? The FIB4 is a very easy test that combines age, AST, ALT, and platelets. There are these calculators on the internet and any web browser. You have this person with 53 years of age, AST is 51, ALT 65, platelets low. This number is 2.2. And again, this falls in the indeterminate range. So if it's below 1.3, your chances of having NASH or with fibrosis are modest or low. If it's above 2.6, equal or greater than 2.67, the chances are very high. And as it gets, I would say, if you break down this area, when it's getting closer to 2.67, chances increase exponentially, like this person in this example. There are other tests like the NAFLD fibrosis score, but we have found that it gives a lot of false positives in that study that I just showed you. The second test that will be very critical in our management of patients is using elastography. And really what it measures is liver stiffness. And in measuring liver stiffness, this is what the device looks like. It gives you a number for steatosis, which is 274 or greater, and gives you a number for liver fibrosis, that anything above 8 is moderate to advanced fibrosis. You probably need to have this checked with your hepatologist. We did a study just recently published in February, and this is our team that helped us work on this. And again, this is really a very talented group of people who have helped me. So I need to thank them. And again, what we found that despite liver enzymes not being very elevated, up to 21% of individuals had advanced fibrosis. Again, steatosis being very, very common. But when we broke it down, what really alarmed us is that 15% have moderate to advanced fibrosis. This means that if in the last 10 patients you did not diagnose anybody with advanced fibrosis, you missed it. So this is why this is important. And again, you cannot rely only on your liver enzymes. You need to rely on other factors like FIB4, imaging, and trying to put the picture together. There are also some commercial tests available, biomarker tests that are useful, like ELF, NIS4, FAST, which is a combination of liver enzymes with elastography. All of those are helpful, and your hepatologist is very familiar with them. So keep that in mind. Finishing with the treatment in the last 10 minutes, the guidance for 2018 is about to be updated this year. And what it shows is that what we know from a lot of many studies, that metformin, great drug to control hyperglycemia and diabetes, but does not have a major impact in NASH. Pioglitazone improves NASH in people with or without diabetes. I will talk about that. GLP-1s at the time of these guidelines only had a small liraglutide study, but Dr. Mandeep Bajaj is going to tell you much more has happened recently, and vitamin E can work in people without diabetes. So in this little guideline, lifestyle is important no matter what stage of NASH you are. Focus pharmacotherapy in people who have F2, F3. We don't have a lot of data on F4. pioglitazone and GLP-1 are the two agents that we have better experience. And again, cardiovascular risk reduction for everybody. Don't stop the statins in your patients. Statins may have even beneficial effects, we think, on liver biology, but they're fairly safe. Now, one thing to remember is, again, what this study has shown is that over 52 weeks of treatment, the benefits that you get on NASH resolution, on fibrosis regression, as you can navigate through this, depending on the weight loss being 5, 7, or 10%, is incremental. Now, the problem is only a minority reach that without pharmacotherapy. And the second problem is that although people can lose up to 19% weight loss, there's a huge variability in the response. So we need to add and help add pharmacotherapy because weight loss alone, even in bariatric surgery, reversal of fibrosis is fairly inconsistent among people. These are the 5 studies. We are happy to publish the first study there in 15 years ago, followed by a couple of studies in people without diabetes. Then we've continued working on this in a 3-year study, showing very consistent results, similar to those in another study in which vitamin E by itself had some benefits, but greatly enhanced by adding pioglitazone, but not greater than pioglitazone alone. Reason why we favor pioglitazone for people with type 2 diabetes. In addition to the liver benefits and reversing NASH, there are a number of benefits that you might be aware in terms of insulin resistance, lipids, reduction of ectopic fat, as we talked at the beginning. It also prevents the progression from pre-diabetes to type 2 diabetes by 80%. And there was another study in people without diabetes called IRIS, published in the New England about 5 years ago. And then it does prevent the progression of atherosclerosis. What we have to watch for is edema, which may happen in 1 out of 20 patients or more if you are on high-dose insulin or amlodipine or have a BMI above 40. The issue of bone loss is probably something that you may want to monitor and do a bone density, particularly in postmenopausal women. Bladder cancer, this debate is, I would say, waning as most studies have been negative. And it's weight gain, what has been a factor that it makes many providers hesitate. So let me show you a couple of things. Number one, the weight gain is from subcutaneous fat. And as you can see here from a prior clinical trial, we did the one that I showed you before. We measured liver fat, we measured subcutaneous and visceral fat. We did a very sophisticated statistical analysis called partial least square discriminant analysis that allows to know which is the factor which is most important in the response to pioglitazone. And these results are very similar to an older study by Miyazaki and Dr. DeFranco that showed pretty much what others have shown. That what happens is that you have a reduction in liver fat, you have a reduction in visceral fat, but your subcutaneous fat, which is more inactive metabolically, increases. Because if you don't stop the excess caloric nutrients, what pioglitazone will do, it will selectively put those excess calories in that compartment, which is the least harmful for you. And it's like putting the toxins in the trunk of your car instead of keeping them, putting them in the engine. That will basically be much more harmful. We would rather have no weight gain. But typically, as you can see here, body weight goes up with pioglitazone. The individuals in this study that lost weight, body weight and subcutaneous fat goes down. But visceral fat goes down more compared to moderate weight loss, and liver fat goes down. And when you look at what this translates into, it translates into improved histology in terms of inflammation, steatosis, and fibrosis. So that's why some of our studies led to improvements in steatosis and in fibrosis in our patients. So to put this together, before I leave you, remember that the targets of treatment conceptually and very simplistically are to reverse the angry and kind of very dysfunctional, sick fat of our individuals who have overweight or who have obesity. Two ways to do it. Either you reduce the mass of adipose tissue by lifestyle changes, GLP-1 receptor therapy that Dr. Bajaj is going to tell you about, or changing the biology of fat, as you can do with pioglitazone, where the receptors for PPAR gamma are 10 times more abundant than any other tissues. There are also direct effects of PPAR gamma on the Kupffer cells, the macrophages that are embedded in the liver, and the stellate cells that lay collagen. But it is important to know that PPAR alpha alone don't have a significant effect on liver fat, nor the PPAR delta or PPAR gamma alone like rosiglitazone. But it is this compound of pioglitazone that I mentioned, or saroglitazar, that's approved for NASH in India as a PPAR gamma alpha, or lanifibranor, where we are awaiting the publication in a major medicine journal of the results of their native study that have been the most promising, as it reverses not only inflammation, but it reverses fibrosis in individuals with NASH. And last but not least, remember that activation with PPAR gamma alpha has broad metabolic effects in all these studies that I'm sure many of you are familiar with. To finish, I'm just going to do a brief introduction to what is coming with Dr. Pandit Bajaj, which are doing many efforts with GLP-1 receptor agonists. Most likely, the best one study was liraglutide, and at the time of the guidelines, the study by Armstrong, the LEAN study, showed histological benefit, although it was a small pilot study. But again, as you see, as weight loss goes down, liver enzymes go down, liver fat goes down. However, there are others. For example, we did a small study looking at the effect of dulaglutide at 1.5 milligram from the diabetes trial, the award studies. Again, with a trend to an improvement. And again, this study also out of India by the group of Dr. Kuchai showed very nicely how dulaglutide may improve liver fat. Finally, this is the study that we worked on, Dr. Newsom being the first author. We published in November last year in a population of 320 patients at the University of Florida. We were one of the most active centers. And again, doses that were daily doses that are equivalent to the obesity, weekly obesity doses recently approved in the United States. And importantly, the majority of people had moderate to advanced fibrosis. So I'm going to let Dr. Bajaj share those results with you, but this was a very important study in the field. One word about SGLT2 inhibitors. Again, many uncontrolled small studies of about 6 to 12-month duration. Some control studies, we did one with canagliflozin showing improvement in insulin sensitivity. And again, always a reduction in liver fat, which we think is more than anything linked to the metabolic changes and the weight loss. And just one slide out of all of these, if you look at the change in body weight, you see that it has a very good correlation here with the change in intrahepatic triglycerides. So more people, in this case with canagliflozin, were able to lose some weight and reverse the state of steatosis in their livers. Again, we don't have any studies really that show in a randomized controlled study effects on histology. But this effect has been similar to that reported with dapagliflozin and empagliflozin and others. So to summarize and conceptualize what I just told you, When you gain weight, you worsen insulin resistance, you increase visceral fat, subcutaneous fat, and you impair the function of your adipose tissue. This promotes type 2 diabetes, promotes and it worsens your cardiometabolic risk. When you lose weight, no matter how, all of this gets better. And finally, when you have mild weight gain associated with the metabolic benefits of changing that sick fat into the fat of a lean, healthy individual, like happens, for example, with pioglitazone or lanifibranor, insulin resistance gets better, the chance of developing diabetes goes down, and your cardiometabolic risk decreases. So to finish, we've learned a lot about these target tissues. I want you to incorporate liver in your equation. We have now agents that work at these different levels, 3 of them possibly having benefit for your patients with NASH. So when you decide your therapies, think about it. I know you're familiar with the ADA choices of drugs. Hopefully in the future, we will add a box and our choices of agents that do something to improve the liver of our patients with diabetes. Again, remember that there are choices. Remember to add pharmacotherapy in individuals that have moderate to advanced fibrosis. Remember the cardiovascular risk reduction. Cardiovascular disease is the #1 cause of death in our patients. Don't forget adding the statin. So take-home message. Fatty liver disease is common, okay? And it should be incorporated in our management in the same way that we have incorporated prevention of nephropathy with albuminuria. And we ask eye exams from our patients with diabetes on an annual basis. It is associated with increased morbidity and mortality. We didn't have time to review the literature, but again, we believe that it is that way. Unfortunately, there's still significant clinical inertia, but I know this is changing thanks to you, hopefully, in the future. The diagnostic algorithm is not as easy as just ordering an hemoglobin A1C as we do for diabetes, but it's improving, and there are some commercial biomarker tests that will facilitate the diagnosis. But for now, remember FIB4 and imaging with elastography. Or again, why is it important today if there are no FDA-approved drugs? Well, remember in India, there is saroglitazar. Pioglitazone is dirt cheap, very inexpensive. And I think it will be for NASH what metformin has been for the management of type 2 diabetes, an early entry and inexpensive choice that may help many of your patients. And you're going to hear what is the role of GLP-1 receptor agonists. And you should know that there are also dual GLP-1 GIP receptor agonists that have had recent impressive results like tirzepatide. Finally, many agents in development, I would say at least 50. And so this is a very dynamic field. So I want to thank you for your time. Please come and visit us. This is our team at the University of Florida. And it's always a pleasure to be at this very, very prestigious meeting. Thank you for your time.
Thank you very much. I think this presentation calls for many, clinical disparity in our country. As a professor of medicine, when I take my ward rounds, and I have developed some simple clinical bedside method by which we can say that this man needs further investigations. Asking for fibra scan in our setting is a very expensive job. As a result of which, we rely on our clinical findings. One finger palpable liver in an obese person and alarmingly elevated SGOT, SGPT calls for a scan. So this is our criteria to decide whom you subject